Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue our GI physiology series. In previous videos, we talked about mastication, salivation, deglutition, and gastric motility. Today, let's dig deeper into gastric secretions. The stomach secretes gazillion things. Most importantly, the hydrochloric acid, the pepsinogen, which becomes pepsin, the gastrin, the intrinsic factor, and even ghrelin. Now let's get started. For maximum understanding and retention, please watch my videos in order. Recall in the previous video when we talked about the control of salivary secretions, we said unconditioned and conditioned reflexes. Unconditioned, you're born with them, but conditioned, you need to learn them. This is also true for gastric secretions. With training, the sight of the food, the smell of food, it's aromatic, as Gordon Ramsay might say. Hearing of the sound of making food, like utensils and cookware, boiling water, etc., can start your gastric secretion before you even eat the food. Just like Ivan Pavlov and the dog, conditioned reflexes. Why did Ivan Pavlov have such great hair? Answer: conditioning. Conditioning works for salivary secretion and gastric secretion. We talked about what happens in the mouth before and the esophagus. Now we're talking about the stomach. Here's the gastroesophageal junction. Here is the gastroduodenal junction. This is the lower esophageal sphincter, and this is the pyloric sphincter. This is the cardiac notch, this is the fundus, the body, the antrum, which is the entry to the pylorus, and then the duodenum. We have two types of digestion, intracellular or extracellular. We're talking about extracellular digestion because this is physiology. For intracellular, you need to check biochemistry, which I also teach. Back to extracellular. What does your gut do? Mechanical and chemical. Mechanical is motility, chemical is secretion. Your stomach has motility, your stomach has secretions. For motility, say thank you to the myenteric plexus in the musculosa. For secretions, say thank you to the submucosal plexus in the submucosa. Here's the wall of the stomach. We have mucosa, submucosa, musculosa, serosa. The submucosa has the submucosal plexus. The musculosa has the myenteric plexus between the inner circular and the outer longitudinal muscle layers. Submucosal plexus plus myenteric plexus are collectively known as the enteric nervous system. Add to that the outside forces. The parasympathetic will try to boost motility and secretion. Sympathetic will try to inhibit motility and secretion. Just like the salivary glands, the gastric glands are also secretory cells. Any secretory cell has to have access to blood supply to get the raw materials from. And then with some modification and some synthesis, you will end up with lovely secretory vesicles until you dish the secretions out. Throughout the entire gastrointestinal tract, the parasympathetic is the friend, the sympathetic is the foe. The parasympathetic family will dilate the vessel. The greater the dilation, the more raw materials will end up in the secretory cells, and the more secretions you will dish out. Conversely, the sympathetic family will constrict the vessel. Less raw materials, less secretions. See, medicine makes so much sense once you understand what the flip you're talking about. The stomach, anatomically speaking, it has the fundus, the body, the antrum, pylorus. Physiologically speaking, we have the proximal motor unit and the distal motor unit. Please refer to the last video. Histologically speaking, it has different types of cells and it has different types of glands. The gland might contain more than one type of cells. Example, oxyntic or gastric glands, oxyntic by the way means acidic, will secrete the acid, of course. Thank you. Parietal cell. So I said the gland contains cell. The oxyntic gland has oxyntic cells. It also has peptic cells for pepsinogen. It also has mucus cells for mucus. How about the pyloric gland then? It has mucus cells for mucus, and it has G cell for gastrin. So we're done with the glands. Let's talk about cells. Mucus cells will secrete mucus. This is true for the surface epithelium and what's underneath it, including in the cardiac region and in the pyloric region. Next, we have chief or peptic cells for pepsinogen, because this is the chief enzyme secreted by your stomach. We also have parietal or oxyntic cell, not to be confused with the oxyntic gland. The The oxyntic cell secretes the acid and the intrinsic factor. For the gazillionth time, this is your enteric nervous system, submucosal plexus for secretions, myenteric plexus for motility. On top of that, we have parasympathetic, which boosts motility and secretion, and sympathetic, which inhibits motility and secretion. Motility is by the myenteric, secretions is by the submucosal. The submucosal plexus has other functions, including regulating the local blood flow and making the nice infoldings. The folds of the stomach are known as gastric rugae. There is a disease where the gastric rugae are especially prominent. It's called Menetrier's disease, not to be confused with Meniere's disease of your ear.
Where is the parasympathetic to the stomach coming from?
It's coming from the vagus nerve, which is cranial nerve number 10. Please recall that we have the left vagus and the right vagus, and thanks to the rotation in embryology, the left vagus will become the anterior gastric nerve, while the right vagus will become the posterior gastric nerve.
And where does the sympathetic to the stomach come from?
It comes from thoracic segments. We will skip T1 and T2 because they are going upwards to the head and neck, some to the thorax, and we'll start about T4, so to speak, or T5. You can also take T6, T7, etc. So let's say T5 to T8. We're still within the vicinity of the greater splanchnic nerve. These preganglionic fibers will continue here. They will not relay in the sympathetic chain, which is the paravertebral group of ganglia, and they will just continue through until they reach the celiac chunk. In the celiac ganglion, part of the aortic plexus, they will relay in this ganglion, and this was the end of the preganglionic fiber. Next, we'll start a postganglionic fiber, which will be very short because the stomach is basically here. So the parasympathetic to the stomach is the vagus nerve, the sympathetic to the stomach is the greater splanchnic nerve. The former is cranio, the latter is thoraco. Next, take a deep breath. Do you remember cell membrane transport? We had passive and we have active. Passive transport, there is no need for energy. The transport will happen along the electrochemical gradient. But with active transport, we do need energy in form of ATP, and we will happen against the gradient. Let's focus on active transport. We had carrier and vesicular. The vesicular is endocytosis or exocytosis, easy peasy. The carrier one has primary active or secondary active. Both require energy. Both are happening against the gradient, i.e. uphill. The question is, who is exerting the energy himself? The answer is primary active. And then the secondary active is dependent on the primary. Primary active transport examples, the sodium-potassium ATPase, which you'll find in every single stinking cell in your body. Calcium ATPase is in muscle cells. Hydrogen ATPase in the kidney, especially in the late distal and collecting ducts, particularly in the alpha intercalated cells.
How about the hydrogen-potassium ATPase?
You find this in two sites. Number one, the kidney, just like this, late distal and collecting ducts in the intercalated cells. And the hydrogen-potassium ATPase is also the proton pump of the stomach that dishes out HCl. When we talk about gastric glands, do you think they are endocrine or exocrine? The answer is both. For example, when the chief cell secretes pepsinogen, this is an exocrine gland. However, when the G cell secretes gastrin, that's an endocrine gland. Which one is faster? Of course, exocrine is faster because we do have ducts and we will turn it to the correct location just right away. But for endocrine, you have to wait until gastrin goes to the blood that's near the stomach. And then this blood will take it to the heart. And then the heart will pump it and then back to the stomach. This is the story of the endocrine glands because they are ductless. Exocrine glands secrete GI enzymes, such as pepsinogen, which becomes pepsin. However, gastric endocrine glands secrete GI hormones, like gastrin, and also somatostatin. Quick review from head to toe. We talked about the mouth before, mastication versus salivation. Mastication, thank you mandibular branch of trigeminal nerve. Salivation, thank you facial and glossopharyngeal. Facial is near your face, i.e. anterior, but the glossopharyngeal is near your pharynx, i.e. posterior. Here is facial, here is glossopharyngeal, and that's your tongue. Pause and review. How many salivary glands do you have? Gazillion. You have 3 pairs of major and you have tons of minor salivary glands. And we talked about all of this in previous videos. Here is the saliva, primary secretion and secondary secretion. Pause and review. The saliva, of course, is hypotonic and alkaline. After your mouth will go to the oropharynx and then to the esophagus. Now let's talk about the stomach secretions. If you're just getting started, please memorize these 3. Parietal or oxyntic cell secretes the HCl and the intrinsic factor. Chief or peptic cell secretes pepsinogen, the chief enzyme of the gut. And G cells secrete gastrin. You should be able to reach a level where I can wake you up from a coma without forgetting these 3. Now, for the pros, you need to memorize 7. Number 1, parietal or oxyntic secretes the acid and the intrinsic factor for vitamin B12. Chief or peptic cells secrete pepsinogen, which will later become pepsin thanks to the acid. When you convert pepsinogen to pepsin, you're converting the inactive to active, and chemically speaking, it gets smaller as it gets active because you're clipping those inactive pieces away. Next, G cells secrete gastrin, the only GI hormone that is pro both motility and secretions of the stomach. All the other GI hormones hate the stomach. Next, of course, you have mucus glands, which contain mucus cells and goblet cells that secrete mucus. By the way, your mucus is alkaline to protect the stomach from its own acid. This acid should help cleanse and destroy and break down the food, not to digest the stomach wall. That's why we need to protect the stomach wall via mucus. And that's why pepsinogen is secreted in the inactive form so that it does not digest the stomach wall itself. Later, when the pepsinogen reaches the lumen or the cavity of the stomach, it can get activated later. Next, we have delta cells, and delta will secrete the doofus, somatostatin. Why do you call it doofus? Because it inhibits everything. It inhibits gastric motility, it inhibits gastric secretions, it inhibits HCl, inhibits gastrin, it even inhibits its own secretions. Also, there is the enterochromaffin-like cells which secrete histamine. Histamine will go to those parietal cells, these oxyntic cells, and will tell them to make more acid. What's the function of the acid? It cleanses your stomach, it's antiseptic, it kills many foreign organisms. That's why most people who go to a dirty restaurant will not develop food poisoning. It can happen, but in many cases you get away with it. Why? Because you have acid in your stomach. But if the acid fails to kill this stinking microbe, you can get sick. You can get sick, but you don't have to get sick.
Hey medicosis, does HCl kill every foreign particle imaginable?
No. For example, rhinovirus is not destroyed by your stomach acid. Not every organism is acid sensitive. What's the function of the intrinsic factor? It will help you absorb vitamin B12 at the terminal ileum. So now you understand the difference between cells and glands. Glands can contain multiple cells. The oxyntic gland contains the chief cell for pepsinogen, the parietal or oxyntic cell for HCl and intrinsic factor, as well as mucus cell. The pyloric glands include 2 types of cells, mucus cells for mucus and G cell for gastrin. Look at that. Here is my oxyntic gland. It looks like this. The gland contains multiple types of cells, such as the mucus neck cells for mucus, oxyntic cells for HCl and intrinsic factor, chief or peptic cell for pepsinogen. Contrast that with pyloric glands. Yes, they do have mucus, same. They have very few chief or peptic cells, but they have the G cells. So the G cells are more close to the pylorus of the stomach. Oxyntic glands are near the body of the stomach. Pyloric glands are near the pylorus of the stomach. Gastric secretions, volume about 2 to 2.5 liters per day. The pH is very acidic. The content that's secreted by the stomach includes water, mucus, which is alkaline. It has the acid, it has intrinsic factor, lots of electrolytes and enzymes. Pepsin is the most famous, gelatinase and lipase are other. Functions of HCl are numerous. It's antiseptic, it kills many bacteria, viruses, fungi, etc. It dissolves food particles, creating a chyme which facilitates digestion and absorption. Moreover, this acid will help you absorb iron and calcium because this acid will turn the ferric iron into the ferrous. from Fe3 to Fe2. And Fe2 can go into the blood. You can only absorb the ferrous. It's very hard to absorb ferric. So where do you think we will absorb iron and calcium at? Just after the stomach, i.e. in the duodenum. Now pay attention because this is going to get crazy. Your vagus nerve can secrete acetylcholine. We already know that. Acetylcholine can boost some acid secretion. But acetylcholine is not the only game in town. That's why giving atropine to treat peptic ulcer is not the best idea, because we have other members. Welcome GRP, also released by the vagus nerve. GRP is called gastrin releasing peptide, which will tell the G cell to secrete, guess what? Gastrin. That's why we call it gastrin releasing peptide. This gastrin will help the parietal cell make more acid, and the gastrin will sneak by and go to different cells known as the enterochromaffin cells to secrete histamine, or I should say enterochromaffin-like cells. And histamine will act on H2 receptor, not H1, H2. This H2 is GS coupled, i.e. it's going to boost cyclic AMP, and cyclic AMP will boost the HCl secretion. This will be very important to understand pharmacology. Do you remember when we talked about this before in my endocrinology playlist? Look at H2. How does H2 work? H2 is GS coupled, which means I will stimulate adenylate cyclase enzyme, which will convert ATP into cyclic AMP. The more cyclic AMP you have in your stomach, the greater the acid secretion through stimulating protein kinase A. But if you are GQ coupled, such as muscarinic receptors M1, M3, and M5, you will act by being GQ coupled. PIP2 will be broken down into IP3 and DAG. You will activate protein kinase C, and you will increase calcium, which causes contraction of smooth muscles.
How about if I'm GI coupled?
GI is the opposite of GS. I stands for inhibitory. Inhibitory to what? Inhibitory of the adenylate cyclase. So cyclic AMP will go down and your stomach will not secrete acid. What did the parietal cell secrete? The acid and the intrinsic factor. The intrinsic factor here is depicted as the orange dot. This orange dot, as you see, is secreted by the stomach, and it will help vitamin B12, this purple color, to get absorbed in the terminal ileum. What do we mean by absorb? It means leaving the gut and going to the blood. If you want to learn more about the story of vitamin B12 metabolism, check out my biochemistry playlist. I have a special video on vitamin B12. Let's make it clinical. Pernicious anemia is a disease where your own antibodies are attacking your own parietal cells in your own stomach. Say goodbye to intrinsic factors, say goodbye to vitamin B12. Without vitamin B12, two things will suffer in your body. Number one, red blood cells. Therefore, you get anemia. You're tired and pale. Number two, the nervous system. That's why you get neurological symptoms. This could be peripheral neuropathy. This could be ataxia. This could be even dementia. So before you diagnose your patient with Alzheimer's disease because you're a doofus and you do not know anything else, make sure to rule out vitamin B12 deficiency before you diagnose with Alzheimer's. When the stomach secretes the acid to the cavity, it has to secrete a base to the blood. When the blood is getting more basic, we call this the alkaline tide. This is very important because students get this incorrectly all the time. They think, the stomach secretes acid, therefore the blood near the stomach has the acidic tide. Shut up. The blood is opposite to the cavity. The cavity of the stomach is acidic, but the blood near the stomach is alkaline. And this will be extremely important when we talk about the duodenum later. Just like every part of your gut, it's under nervous and hormonal control. The exception was the mouth. The mouth was purely nervous. The stomach has nervous control and hormonal control. Nervous control for the stomach is the enteric nervous system, myenteric and submucosal, parasympathetic and sympathetic fibers. Hormonal, we have the GI hormones. So let's talk about them. We will review them quickly because we talked about all of them in a separate video. GI hormones are collectively known as enterogastrones because they are hormones that are made by the stomach and the intestines. All of them come from the upper part of small intestine except gastrin, which comes from the stomach and the upper part of small intestine. All of them hate the stomach, which means they decrease gastric motility and secretion, except gastrin, which boosts gastric motility and secretion. Here is the lovely gastrin made by the G cells near the pylorus of your stomach. Gastrin is also released by cells in the upper small intestine. Gastrin will boost gastric motility and secretions. It will also increase the growth of the gastric mucosa and, to a certain extent, might boost insulin release after a meal. What are the factors that trigger gastrin release? Just the presence of food in the stomach, the distension of your stomach by the food, raising the pH of the stomach. Why is that? Because the food that you're eating is not as acidic as the stomach. So once food gets added to the stomach initially gets more alkaline. And this slight rise in the pH will boost gastric secretion to secrete HCl to bring the pH back down between 1 and 2. And don't forget vagus, especially by the gastrin-releasing peptide. It's called gastrin-releasing peptide because it's a peptide that releases gastrin. Duh. Let's put it all together. This is the cavity of the stomach. All of this is the parietal cell that lines the stomach. And this is the lovely blood vessel, which is part of the extracellular fluid, as you know. Remember that the extracellular fluid includes plasma and interstitial space. Let's go. Begin with the end in mind. What are we trying to achieve as a parietal cell? I am trying to put acid into the cavity. Nice. This acid is positive, correct? Yeah. When you secrete something positive, you better reabsorb something positive in exchange in order to preserve the law of electroneutrality. Who's that positive? Potassium. So potassium is going towards the blood.
Okay, I get it. Where did I get the potassium from?
Well, potassium is everywhere. It's very abundant intracellularly. It's also present in your food. So that's easy.
But where did I get hydrogen ions from?
Now that's the real question. You got it from carbon dioxide, which is the result of the metabolism of any cell in your body. It's going to release carbon dioxide. Water is everywhere. 60% of your body is made of water. Carbon dioxide plus water equals carbonic acid. Thanks to the enzyme carbonic anhydrase. Carbonic because it works on carbon dioxide. Anhydrase, anhydro, no water. It's going to remove the water and give you something that does not have water in it. Carbonic acid. It is hiding the water from the medium, so to speak. And this carbonic acid will dissociate into the acid, which will go to the cavity of the stomach to help you digest and cleanse the food. And the base, which will be absorbed to the bloodstream, #alkaline tide. Normally, the pH of your arterial blood is about 7.4. The more acid you dish this way, the more base you will dish this way, and the pH might rise to 7.5, 7.6, 7.7. But am I going to die? Shut up. Later, when we talk about the duodenum will do the exact opposite. Bicarb will go this way, and the acid will go to the blood, causing an acidic tide near the duodenum, which will neutralize the alkaline tide coming from the stomach. So in the end, everything will be hunky-dory, and your blood will go back to the regular pH, which is 7.4 in the arterial blood. Back to the story of bicarbonate release or absorption into the blood. Okay, bicarbonate is going this way. Bicarbonate is negative. You need to exchange something negative instead. So the chloride is going to enter, and you will see the chloride here. Now you have H and Cl. What do you call that? HCl, hydrochloric acid, an isotonic solution.
Okay, Medicosis, you said isotonic solution. Where is the solution? Where is the solvent?
Oh, water is gonna follow you by osmosis. Alright, who made all of this? The lovely primary active transport hydrogen potassium ATPase pump, which is found in the stomach, parietal cell, and in the kidney, late distal and collecting ducts in the intercalated cell. How can we stimulate this pump? Well, thank you cyclic AMP, because H2 receptor is GS coupled, and H2 receptor is stimulated by Histamine. Where did that histamine come from? Enterochromaffin-like cell. Who stimulated these cells? Gastrin. Where did gastrin come from? From the G cells of the stomach under the influence of GRP, which was secreted by the vagus nerve. Moreover, the vagus will secrete acetylcholine, that's a cholinergic fiber. Acetylcholine will bind to a muscarinic M3 receptor on the parietal cell. Both the M3 receptor for acetylcholine and the CCKB receptor for gastrin are GQ coupled. GQ coupled, DAG and IP3, protein kinase C, lots of calcium please. Calcium is the hero of contraction. It's gonna contract and rotate this lovely primary hydrogen potassium ATPase pump. Hydrogen out, potassium in.
How can I inhibit this proton pump and decrease the acidity in my stomach?
Well, fear not, because you have prostaglandins and you have somatostatin.
Oh, the doofus that's made by the delta cells?
Yes, the doofus that inhibits everything because it's GI coupled. I stands for inhibition. When you inhibit cyclic AMP, you will inhibit the proton pump and you will not release acid into the stomach lumen. You can take this to the next level by adding pharmacology on top of it. The pharmacology of peptic ulcer disease has been discussed in my Utacoids pharmacology course that you can download on my website medicosisperfectionalis.com. Since iron and calcium needs HCl, they will be absorbed in the area just close to the stomach, which is the duodenum. Remember the great Ellie's mnemonic. First, you need to iron your clothes, then fold them and put them in the closet. Iron first, duodenum, fold them, folate next in the jejunum, and closet cobalamin last in the terminal ileum. Thank you, intrinsic factor. Bile salts are also absorbed in the terminal ileum. Please remember this. This is called the enterohepatic circulation. We'll talk about it later. What are the phases of gastric acid secretion? Cephalic phase, the conditioned and unconditioned reflexes. If the food is already in my mouth, it's unconditioned. Before the food reaches my mouth, just smelling the food, hearing the sounds and the noises of food preparation can trigger not just salivation, but also gastric acid secretion. And for this, you should thank the medulla and the vagus nerve. Next is the gastric stimulatory phase. Of course, the stomach is pro-stomach. Yeah, the stomach is pro-gastric. It's pro-acid. And this is under nervous and hormonal control. Nervous reflexes include local short reflexes of the enteric nervous system and distant long reflexes. The vagus will take you to the brain and back to the vagus to the stomach. Vago-afferent, vago-efferent. The endocrine is just G cell secreting gastrin. Both of these are boosting gastric acid secretion. Who hates the stomach? The intestine, the duodenum. Why? Because the duodenum needs an alkaline medium in the cavity. The stomach is dishing acid and throwing it on the duodenum. Of course, the duodenum is going to hate this. So the duodenum has its own reflexes called entero from the intestine to the stomach, enterogastric, and it also has gazillion other hormones that will decrease gastric acid secretion. I've told you before that only gastrin loves the stomach secretion. All the other GI hormones inhibit gastric secretion. The stomach needs to protect itself from its own acid so that you do not end up digesting your own stomach wall. The stomach has prostaglandins. Prostaglandins stimulate the mucus cells to make mucin or mucus, which has bicarbonate, ergo alkaline, which will protect your stomach from the acid. Don't forget that prostaglandins are also GI coupled, which will inhibit the proton pump, which will decrease acid secretion. So prostaglandins are good for your stomach for two reasons. Number one, they boost mucus secretion. Number two, they inhibit the proton pump. Next, you have strong tight junctions between one and the next stomach cells, which will block the acid from flowing inwards. Moreover, the membrane of the stomach cell is impermeable to H, which means H can be in the cavity, but it cannot enter into the cell of the stomach.
What if it did enter?
We will actively push it outside. You spend energy, ATP, to dish it out in exchange for sodium. What are the pro-acid factors in the stomach? Vagus is pro-acid, acetylcholine, GRP, gastrin, histamine, HCl, and the reflexes long and short, local and global. How about the anti-acid factors? Prostaglandins hate the acid, tight junctions hate the acid, the membrane hates the acid, and we actively push it out. Don't forget that the intestine hates the stomach acid. This is the intergastric reflex, that's the nervous, and also hormonal. Somatostatin, CCK, secretin, GIP, VIP, etc., all of them will inhibit gastric acid secretion. Prostaglandins are very good for your stomach. They protect the stomach, especially the prostaglandins made by cyclooxygenase 1. That's why aspirin and nonsteroidals are evil when it comes to the stomach. They block cyclooxygenase, including cyclooxygenase 1, and before you know it, you have no prostaglandins to protect you. That's why if you take aspirin for a long time or nonsteroids for a long time, you're increasing your risk of gastric ulcers big time. If you want to learn about the difference between cyclooxygenase 1 and cyclooxygenase 2, download my Utacoids pharmacology course. Is the stomach good for digestion only, or can it absorb? It can absorb very few molecules, especially alcohol and aspirin. Aspirin has a great story because it's known as acetylsalicylic acid. Aspirin is an acid, and the stomach has acid. If you put an acid in an acidic medium, you will favor its absorption. Like absorbs like in pharmacology. Just like dissolves like in chemistry. Let's take it to the clinic. We'll talk about pentagastrin, Zollinger, Ellison syndrome, Meckel's diverticulum, and peptic ulcer disease quickly. Pentagastrin is a synthetic gastrin. Take the natural gastrin, not all of it, just the terminal 4 amino acids. Add alanine amino acids to it, and before you know it, you have a synthetic gastrin known as pentagastrin. It can be used pharmacologically if you do not have gastrin, such as if you removed your stomach, gastrectomy surgery. Next, Zollinger-Ellison syndrome is a gastrinoma. It's a tumor that releases lots of gastrin. Lots of gastrin equals lots of acid. Your patient has symptoms of peptic ulcer disease that does not respond to antacids, does not respond to proton pump inhibitors, does not respond to H2 blockers, does not respond to eradication of H. pylori, does not present with one ulcer but many ulcers. What the what? And the ulcers are not just in the stomach, not just in the duodenum first part, they also extend beyond the first part of the duodenum, which is very unusual. Oh, by the way, your patient has watery diarrhea. What the flip is going on? This patient has a tumor that releases too much gastrin. You can measure their serum gastrin level, it will be high. You can try to suppress that gastrin, you will fail because cancers do not care about your stupid test. Cancer is not gonna obey your arbitrary rule. It's cancer, it keeps dishing out stuff. You can do a CT scan with contrast of the abdomen and you will see the tumor. The treatment is surgical removal of the freaking tumor, and after you remove it, you can give proton pump inhibitors. They might help with the metastatic disease if this tumor went elsewhere. Next topic, Meckel's diverticulum. First of all, what's the difference between a diverticulum and a polyp? Easy. A polyp is an inward pouch towards the lumen. A diverticulum is the opposite. The diverticulum is an outward pouch. Polyp versus diverticulum. Meckel's diverticulum is an outward pouch. Where do I find it? It's in the small intestine, 2 feet proximal to the ileocecal valve.
2 feet, isn't that too much?
Don't forget that your intestine is so long. The diverticulum itself is 2 inches long. Meckel's diverticulum is 2 times more likely in males than in females. Usually the patient presents at 2 years of age.
What's the problem with this diverticulum?
Well, the problem is the diverticulum is carrying 2 types of ectopic tissues, gastric tissue and pancreatic tissue. In pathology, when you're carrying something that does not belong here, it's called a choriostoma. The gastric tissue will give you too much acid, too much ulcers. The ulcers can bleed. One of the most common causes of hematochezia, which means blood in the stool of a baby, is Meckel's diverticulum. If the baby is properly fed, he should not be having iron deficiency anemia. What the flip is going on? Meckel is going on. The other type of tissue is pancreatic tissue.
How can I find these ectopic tissues?
You can find them radiologically via technetium scan, which is a nuclear scan. Management is by surgical resection. When you remove a diverticulum, it's called a diverticulectomy. When you open the belly wide open, it's called laparotomy. If you do it with a laparoscope camera, it's laparoscopically. Next, peptic ulcer disease. What's the problem? Imbalance between the proacid forces and the anti-acid forces. This can remove the epithelium, erosion, or remove the epithelium with the underlying basement membrane, ulcer. The ulcer can bleed and perforate, bloop, before you know it, you can die from internal bleeding. Or the acid can reflux upwards to your esophagus, giving you heartburn. And then, over the years, Barrett's esophagus, which is a metaplasia. And then, over the years, esophageal adenocarcinoma, which is a cancer.
How can we nip it in the bud before all of this crazy stuff happen?
Well, lifestyle modifications. Improve your diet and exercise. Do not eat too much before going to bed. And there are pharmacological options that try to decrease the stomach acid by targeting the proton pump. These medications include, but not limited to, histamine 2 receptor blockers, proton pump inhibitors, prostaglandin analogs, antacids, and cytoprotectives to protect the stomach from the acid. All of these medications were discussed in my Utacoids pharmacology course. Download it today at medicosisperfectionalis.com. It has 21 videos with cases and answers. If you want to learn about the hydrogen potassium ATPase pump in the kidney, download my renal physiology course. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense. Peace.